My name is Abhishek Jain. I'm the radiology consultant who work at the Royal Liverpool, and welcome to this webinar. This is the first time I'm doing this webinar, so it's a bit strange talking to people in different parts of the country and not being able to see them. But yeah, hopefully I'll keep you all awake for the next 40 minutes or so. I have nothing to declare, and in the next, say, about 30 to 40 minutes, we will be going through the cross-sectional anatomy of the spine, the various appearances of the CT and the MRI. We'll be also touching on the protocols, and then we'll be diving into pathology. Now, I do understand that there is a varied audience, and it might be a bit basic for some of the people, but it might just act as a good refresher for you. So, just coming to the basic anatomy of the spine, the cervical, the thoracic, and the lumbar vertebrae are slightly different to each other. The cervical vertebra are slightly peculiar in the way of having a foramen transversarium, which you see. So this is where the vertebral artery runs. And the first cervical vertebra, the body is actually missing, and it gets attached to the C2 vertebra, and that forms the dens. So that's just the anatomy of it. And alongside that, we've got what we call as uncovertebral joints within the cervical spine. So it is more over the lateral aspect of the vertebra, which is a synovial articulation, and that can get involved with spondyloarthropathies and other pathology as well. So just something that you need to be aware of. Now, the foramen transversarium extends up to the C6 vertebra usually, but it can be present in about a minority of the cases in the C7 vertebra as well. So just something that you need to be aware of. As regards the thoracic vertebra concerned, because we've got 12 thoracic ribs, there is a facet for the articulation of the rib with the vertebra itself, and it's got a superior and an inferior costal articular facet. There's a lumbar vertebrae that is absent. So looking at the CT picture, we're just the basics again: the vertebral body, the pedicle, which connects the vertebral body to the posterior elements. Strongest part of the vertebra itself, the pedicle, because it's like really dense bone. And this is what you see on your plane radiographs, and there's pathology, the owl's eye on the plane radiograph. Then we've got the facet joint, and we've got the lamina and the spinous process. Now, looking at the MRI scan, we have got the standard MR sequences that we do is a T2 weighted sequence, which is very good for look at the CSF spaces and also any cord pathology. So what we are looking for is the vertebral body, the alignment of it, the intervertebral disc spaces, the ligaments that are attaching, looking at the craniocervical junction, the cervical cord, looking at the CSF spaces as well. And within the cervical vertebra, the nerves that are exiting are more in sort of a horizontal fashion, as against the sort of a more oblique orientation of the within the lumbar spine. I'll come to that in a minute. Now, there are 8 cervical nerves, and the way we accommodate them is the first cervical nerve exits above the C1 vertebra. The second cervical nerve exits above the second cervical vertebra, and so on till the time we reach the C7 vertebra, where the 7th cervical nerve exits above the C7 vertebra. The C8 nerve, however, exits between the C7 and the T1, and then subsequently all the other nerves in the thoracic and the lumbar vertebra exit below the level of the neuroforamina. So looking at this lumbar spine MRI scan, just one of the sagittal parasagittal imaging on a T2 weighted sequence, you see the neuroforamina and all the nerves within the lumbar vertebrae. The L5 would be coming out or exiting underneath the L5 vertebra. The L4 would be exiting underneath the L4 vertebra, and so on and so forth. The conus usually ends at the level of the L1 vertebra. If it's lower down, then obviously you're looking at diastematomyelia or other pathology. If it's high, then again, that is something that needs to be mentioned into the report. So if you're looking at an axial image, you're looking at the vertebral body, then we look at this is the portion of the intervertebral disc. We're looking at the spinal canal and looking at the exiting nerves. So some people call it as nerve roots, some people call it as nerves. Being a purist, it will be classed as a nerve which is seen in that particular area. That's the facet joints, the spinous processes, and you're looking at the paraspinal musculatures as well. So just going through what an MR scan would look like on the sagittal imaging. So this is a standard T2 weighted imaging. So what you look for is so in the report you put in what's the alignment of the vertebra. So the vertebra maintains normal alignment. Is there disc dehydration at any level? In this particular case, there is at the L4, L5 level, there is minor disc dehydration. Same thing happening at the L5S1, which is more pronounced. Whether there's any sort of disc protrusion, what's happening to the spinal canal, whether or not this is causing any significant canal compromise. I'll come to that in a minute, but this is what you need, or everything that needs to go into the report. Then we're looking at, is there any sort of collapse of the vertebra itself? What's the marrow signal like? So for that, you would look in the T1 weighted image. This is a T2 weighted image. That's again, a T2 would be able to tell you something about the marrow signal as well. Looking at the vertebral end plates, and then kind of coming out in the more parasagittal region, and you're looking at the neural foramina again, and you see that sort of a keyhole appearance, and the central portion of the key, the hole or the dark bit, is the nerve coming out, and surrounding that is the epidural fat. It's not just the CSF, it's the epidural fat, because if you look at the T1 weighted image, again, you can see that this is bright. So that is again the epidural fat which you see within the neural foramina. So again, the nerve over there, the keyhole, that's the epidural fat. And in this particular case, you can see that there's a disc protrusion which is causing indentation of the thecal sac, but the neural foramina seems to be clear. That's the region of the facet joint, and again, you can see that that's a bit degenerative as compared to the other facet joints over here. So just all the things that needs to be incorporated into the report. Also, we'll be looking at the marrow signal. On a T1 weighted sequence, the vertebral body should be brighter than the intervertebral disc, and you should be able to compare the subcutaneous fat signal to the vertebral body signal. Why is that important? I'll come to that in the subsequent slides. Again, we're looking at the axial imaging on the T2 weighted sequence. So some places do a T1 weighted sequence as well. In the standard protocol, we just do a T1 and T2 sagittals and an axial T2. And on this particular example, you see the vertebral body, then we're going into the level of the disc, and you're looking at the nerves which are exiting out. That's the neural foramina, the facet joints, the spinous processes, the paraspinal musculature surrounding it. Also look at the prevertebral areas as well. Obviously, you look at the aorta and the IVC as well. There's sometimes can be pathologies in that particular area which can easily be missed. Paraspinal lymphadenopathy is again something which is important not to miss. So a quick word about the transitional vertebra. So it's important to number the vertebra correctly. Transitional vertebra, usually you see that at the level of the lumbosacral junction, and plenty of articles out there, but we don't have a proper consensus as to what is how to define a lumbarized or a sacral vertebra or a sacralized lumbar vertebra. The way we describe it is that if you think that there is a subtle abnormality in that area and you don't know whether this is an S1 vertebra which forgot to fuse to the sacrum, or an L5 vertebra which is partly fused with the S1, we call that as a transitional vertebra. The reason why this is important is that when you put that in the report and you say that, so if you take this as the L5 vertebra, where the arrow is, and anything above that would be the L4, the L3, L2, and L1, and then you will number the nerves accordingly. When you put that in the report, and if the patient needs spinal intervention of any description, and they would be doing it under fluoroscopic guidance, and this is what the spinal surgeon or the MSK or the neuroradiologist would be looking at when they're doing their spinal intervention work. They would be classing one particular vertebra. So if you imagine there's a bit of a discrepancy between what is this, somebody might just say this is an S1, which has got a slightly odd appearance, and in which case they can be having medical legal implications and clinical implications as well. So the way we phrase it is that if you think that this is the L5 vertebra, you'd say that this is a transitional segment, and for the reporting purposes, there is a residual disc seen at the L5S1, and so the other nerves which are getting pinched are at a particular level. If you want to be a purist and you want to say that whether this is a lumbarized or sacralized vertebra, you need to image the whole spine and then you calculate it from the C1 vertebra and count the number down. So something to be aware of. Now we're diving into the pathology. So starting off with trauma, then we go into degenerative change, infection, tumor, and metastases. So when we're looking at the MRI, as I've already discussed it, we look at the sagittal T1, which is good to look at for the anatomy and for the marrow. It's a sort of a rich man's plain film, the T1 on the MRI sequences. The T2 is to look for any cord and nerve pathology, and again, anything which has got any sort of inflammation or any pathological process, there will be some amount of edema, and they're looking for any high signal on the T2 weighted imaging. Then we look at the axial T2. This is the sort of workhorse for most of the standard MSK neuroimaging. Some people do add an axial T1 to the sequence, but that's not what we do in our usual practice. A stir is reserved when there is a doubt about infection, inflammation, or tumor. Plenty of examples to follow. And then in the postoperative spine, or in the tumor protocol, we also add a contrast enhanced scan, but that's again reserved just for a postoperative or tumor protocol, and again, or for any sort of problem-solving cases. So when you're looking at a trauma film, just like you would have looked at on a plain radiograph, you just look for the alignment, the bone, the soft tissues, and also with the MR, and to a certain extent, CT, you can predict or suggest a cord or a nerve injury. So this is a sort of a volume rendered CT, and you look for the alignment. So you're looking for the anterior spinal line, which is outlined in yellow, the posterior spinal line, which is outlined in green, the spinal lamellar line in blue, and the spinous process line, which is outlined in red. So all these should be in alignment. The only thing about the posterior spinal line is, the spinous process line is that the C2 to T1 are all in alignment, and the C1 is just off it. That's just a normal sort of appearance of the cervical spine, but you need to make sure that the anterior, posterior, and the spinal lamellar line are all in alignment. Now there are different mechanisms of injury. So it's always important to bear that in mind, because that's going to have a major implication on how you would be reporting these cases. So looking at the head extension and tension, the head impact, hyperextension injury or compression injuries, and that would lead to different sort of injury manifestations within the cervical spine. A low risk criteria, this is just to be something that you need to be aware of. The Nexus criteria, Canadian C-spine rule, different trusts follow different protocols. But these are the sort of low risk criteria for having a cervical spine injury. So these are the patients who would not definitely need a cross-sectional imaging. So I'm going to go through a few fractures. So this is an occipital condyle fracture. So always, just when you're looking at the CT of the brain, it's important to look for the base of skull fracture. But in this particular case, there's a fracture of the occipital bone, which is extending into the occipital condyles. So when you're looking at a C-spine, make sure that you look at the base of the skull as well. And then when looking at a CT brain, make sure if it's a trauma brain, then always look for what's happening to the odontoid peg and to the occipital condyles and other structures that you can see. Usually you'll be having both the brain and the cervical spine to report together. But if you're having any sort of investigation in isolation, just make sure that you kind of cover the base, so to say. And that's kind of extending into the occipital condyle C1 articulation as well. So that's again not going to have a bearing, because it just makes it an unstable injury. Going to a C1, this is an eponymous name for a Jefferson fracture, which is basically a compression fracture, and that kind of leads to it's just sort of a burst fracture of the C1, and you can see the anterior arch and the posterior elements are all fractured, and alongside that there's a fracture through the through the vertebral foramen, which is basically, that's where the vertebral artery would be running. And you can imagine that this would be sort of highly suspicious of any sort of vascular injury. It could also lead to dissections, it could lead to transection. So something that needs to go into the report. If you are in any doubt that there might be a vascular injury, then the patient would be needing a CT angio, just to make sure that there's no sort of vertebral artery injury. Something that needs to be put in the report. Coming to the odontoid peg fractures, or the odontoid fractures, they're kind of the different types. So type 1, type 2, and type 3. So type 1 is just at the tip of the odontoid peg. Type 2 is going through the base, and the type 3 is basically extending into the C2 vertebral body. Again, everything that needs to go into the report, and it's got implications on the treatment. The type 2 and the type 3 are the ones which are unstable and then can lead to non-union. A hangman fracture is something which was seen in judicial hanging. It's also seen in high velocity motor vehicle accidents where there is hyperextension and distraction injury. So you can imagine that the force vector is kind of pulling the neck back and also distracting it at the same time, and it is bilateral pars interarticularized fractures, and you can see that it's kind of all distracted. And again, on the sort of axial image, I find these 3D imaging quite useful, because quite useful for the clinicians as well. Facet dislocation is again something that we encounter quite frequently. Then it could be unifacetal or bifacetal dislocations. So this gives an appearance of a perch facet. So always look for the alignment. So in a CT report, it would say whether the vertebral body height is maintained. Is there a fracture? Is there any facet dislocation? And also looking at the soft tissues. There's a hyperextension injury, which we describe as a teardrop sign. So it just looks like a tip of an iceberg sort of a lesion, but especially when you're looking at on the plane radiograph, you just see the anti-inferior corner of the vertebral body being avulsed, and you think that, well, it is just a minor injury. The important thing is that that's a sort of a distraction injury, and leads to distraction of the anti aspect of the vertebra and compression of the posterior aspect, and you see that there's a compression fracture over the posterior elements over here. Important thing to bear in mind is the normal variance. So if there are normal variants, they can be sort of fusion abnormalities especially of the C1 and the C2, and you can see that there is an anti-arch in the posterior arch which is unfused. And the way to sort of differentiate that from a fracture is that that's sort of having a smooth margin, it's well corticated, and you look for the surrounding soft tissues, and if there is any sort of there's an absence of edema or hematoma, then it is more likely to be a normal variant. This is the nos odontoidum, so again the odontoid peg is not fused with the C2. Again, if you do an MRI scan, you'll have an absence of any marrow edema in that particular location. The other thing on a CT is that it'll be well corticated, and you will not have any sort of soft tissue abnormality. So again, something that you can put in the report, and then give an argument for why you think this is a normal variant, or is this a possible fracture. When you come under the MRI scan, it's important to look for, so MRI scan is reserved in cases where you're looking for any sort of ligamentous injury or any cord injury. These are two really dramatic examples where there is a complete distraction injury, and there is cord impingement, and there is myelomalacic change as well. You can see that the anterior longitudinal ligament is gone, the posterior longitudinal ligament is gone, and the interspinous ligaments are gone as well. So it's just kind of gone through and through the whole cervical spine. You can imagine what would have happened at the time of the injury. This is what you're seeing is a couple of days or hours or whatever later that you're seeing all these changes. This is a more dramatic example of complete transection of the cord. So that's the sort of indications for doing an MRI scan. So anytime you have a neurology, you should have a low threshold for doing MRI scan. For nerve injuries, we can do MRI scan. This is usually reserved for sort of a later sort of presentations where there is this is edema around the nerve. So this is like a traction injury, and there's another example where there has been a root avulsion and has led to a pseudomeningocele formation. When it comes to thoraco-lumbar spine, you look at the sort of the column injury classification has kind of gone out of vogue now, and then what you're looking for is what's happening to the ligament structures. So you've got the anterior longitudinal ligament, the posterior longitudinal ligament, and the posterior ligamentous complex, which comprises of the interspinous, the supraspinous, and the ligamentum flavum. So those are the things that we look for, and we are asked whether there is any sort of PLC injuries, which is the posterior ligamentous complex injury, again comprised of ligamentum flavum, the interspinous, and the supraspinous ligaments, and this is all what used to be called as the sort of a posterior column, and that just kind of, if these structures are damaged, then you render this as and sort of an unstable injury. Again, an example of this PLC corner injury is that there is compression of the vertebrae, so it's a grade 2 compression fracture. There is a sort of subluxation of the facet, and alongside that there's damage to the posterior ligamentous complex. In case on the MRI scan, you can see that that's the normal sort of interspinous ligaments. That's all disrupted. The ligamentum flavum is disrupted, and you see the vertebral compression fracture over here. Coming to degenerative change, so what we look for, this is more like a bread and butter for spine imaging. It's like looking for disc dehydration, osteophytosis, and degenerative change in the facet joints. So you would have heard something called as like the Modic Changes. So what Modic Changes is something very similar to what we would see in any of the degenerative change in the rest of the body. So what you look for is that there is damage to the sort of subchondral bone. That's what we see on the plane radiograph. So when we say subchondral sclerosis, so that's the sort of similar sort of thing that you're looking at on the spine as well. So on the T1 and the T2 weighted sequence, so basically what happens is that initially there will be disc dehydration, which alters the biomechanics at the level of the vertebral end plate. That leads to sort of excess strain going through the vertebral body, because you've got that loss of that spongy sort of bouncing effect of, or sort of shock absorbing effect of the intervertebral disc. That leads to excess strain at the level of the vertebral end plates, and then that would lead to bone marrow edema-like patterns. So it will be bright on T2 because it's fluid and there is edema. There's going to be bright on T2 and sort of darker on T1. That's a grade 1 or type 1 modic type change. The grade 2 will be, as time would progress, there will be sort of more sort of reparative process, so there will be a bit more of the fatty infiltration which will happen, and that is what we call as a grade 2 or type 2 modic degenerative change. So that'll be bright on both the T1 and the T2 weighted sequences. Then we go to the last stage would be fibrosis or scarring. So the bone scars and leads to sclerosis, and you will see dark signal on both the T1 and the T2 weighted sequences at the level of the vertebral end plate. So type 1 modic change, more edema-like pattern, so low on T1, bright on T2. Then it will be type 2, will be more fatty infiltration, bright on both T1 and T2, because fat is bright on both T1 and T2 weighted sequences, and then it leads to scarring, fibrotic scarring, or the sclerotic bone, which is dark on both T1 and T2 weighted sequences. When you're describing the zones in the when you're coming into degenerative spine, you have to sort of be very particular as to where the nerve is getting pinched, because that will have an impact on what level the surgeons would be operating on. The other thing is that there can be a nerve which is getting pinched at a higher level, and so it might be the L5 nerve getting pinched at a neural foraminal level, or higher up at the level of the central or the paracentral zone. So that's something that needs to go into the report. So you have centrally, you've got the central zone, then it is a subarticular zone, or what we call as a paracentral region. Then there is a foraminal zone where the nerve is actually exiting. So so that's the region of the foraminal zone, and then you've got the extraforaminal zone, and then it goes into the far lateral zone. So imagine this is the L5 nerve, which is exiting between the L5 and the S1 vertebrae. This can be either getting pinched at the level of the foraminal zone, it could be either getting pinched at the level of the extraforaminal zone, or it might be getting pinched higher up over here between the, so this is, if this was the L5, this would be the L4 vertebra on top, and it might be getting a bit pinched at the L4, L5 level. So depending on where the nerve is getting pinched will have an implication of where they would perform the surgery. So that needs to go into the report. So whether this is a traversing nerve where it's sort of traversing and then it exits over here. So up till over in that region, it'll be the traversing nerve, and when it goes into the neural foramina and beyond, it is the exiting nerve. So that's something to bear in mind when you're putting the report up. When looking at disc herniation, it's again, as I said, it's something to do with the sponginess of the intervertebral disc. So you've got the annulus fibrosis over the periphery and the nucleus pulposus in the middle. Over time, with the disc dehydration, the disc becomes a bit more squashed, and then that loses spongy nature, and that leads to sort of disc herniation, which is losing its normal sort of morphology and becoming more disc-like over here. So from the normal discoid shape, it is becoming more squished up. So the different variants of it is called this, or different grades of it are called the protrusion, extrusion, and sequestration. So within the protrusion, you have got some disruption of the annulus, and then there is a bit of protrusion of the nucleus over here, but still contained within it. So you can see that there's disruption of the few of the fibers, and then the nucleus is started to bulge out. So that is more of a protrusion. The other way of describing it is that if the width is greater than the depth of it, then it is called as a protrusion. Moving on, leads to extrusion, where there's more disruption of the annular fibers, and then the material starts coming out. So that's an extrusion. So in an extrusion, the AP dimension of the extrusion is more than the transverse dimension. So that is an extrusion. And then eventually this part of the nucleus gets separated and leads to a sequestration. So this is called as a sequestered disc. And sequestered disc material could actually migrate cranially or caudally, but it might go into the neural foramen as well. So that is something that we need to mention in the report, because if that's the sequestered disc which is causing compression, then the surgeon would go in and try to take that sequestered material out. Just on the axial image, these are the T2 weighted imaging. So this is sort of a normal appearance, and then this is a diffuse disc bulge, and you can see how the disc is bulging. So no prizes for getting that, just a normal disc bulge. Then it comes to the protrusion. Again, the width of it is more than the depth, so that is a protrusion, and you can see that's the nerve on the right and that's the nerve on the left, and that's causing pinching of the nerve against the facet joint over there. So and it is causing the pinching of the traversing nerve. So this nerve would exit intervertebral foramen and lower down. So this is the traversing nerve. Then you go to extrusion, which is the nerve getting pinched by this material, which looks like a disc material. So you can see that the intensity is almost the same as the disc, and it's extruded out where the depth is more than the width. So that's the extrusion, and then eventually it might just gets detached from the parent disc and lead to sequestration. Coming to an entity called a spinal canal stenosis. So looking at the spinal canal, so you've got the CSF in this area. So always good to look at on the TT weighted sequence. You've got the nerves which are running around, and those are the normal disc. In this particular case, is a herniated disc which is coming out, and it is causing indentation of the thecal sac. So you can imagine that if the disc herniation becomes a protrusion or extrusion, or even a large disc herniation, that can lead to spinal canal stenosis. The other thing to bear in mind is sometimes there can be congenital narrowing of the spinal canal itself, and on top of that, if the patient have even a minor disc herniation, that can lead to significant spinal canal stenosis. So an example where there is an extrusion of the disc material, and you can see that the CSF space over here is nice and preserved, and over here it's almost getting pinched. So this is like moderate to severe spinal canal stenosis, and that can lead to the cord-equina compression or cord compression. So those are the things that need to go into the report. So moving on to the spinal metastases. So what we look for is when we do these sequences, we do the T1, T2, and a stir sequence. The reason for adding a stir sequence is that it brings down the fatty content in the marrow and just sort of brightens the area wherever there is inflammation or any sort of abnormality, inflammation, infection, or a tumor, and it lights up. So that's why we do a stir image. It could be lytic or sclerotic. The way we sort of differentiate it from the other pathologies is there will be bulging of the posterior cortex of the vertebral body. There could be an extraosseous soft tissue component and involvement of the pedicle. So these are the three signs that we look for whenever we see a marrow signal abnormality within the vertebral body or in the posterior elements to sort of suggest in the report whether this could be related to spinal metastasis or not. So looking at this area of spinal metastasis, so this is a T2 weighted sequence, a T1 weighted sequence, and a stir sequence. So we've lost this normal fatty marrow is lost on a T1 weighted sequence. That should raise alarm bells. And when you look at the stir sequence, the fat is all darkened out because of the inversion recovery, and it's only the fluid or the pathology process which sort of brightens up. So this is all sort of brightened up. So this is what is consistent with spinal metastases. On a T2 weighted sequence, it might be a bit difficult to ascertain the diagnosis. So that's why a T1 and a stir sequence is very helpful in the cases of finding out whether this is spinal metastasis or something else. Looking at another example where there is the abnormality, and you can see that this is sort of diffuse marrow infiltration, but alongside that there is this extraosseous soft tissue component, and that's again consistent with metastatic deposit. It could be a primary pathology, but then you see all the other changes within the rest of the vertebrae, which will sort of equate to there's some sort of a background changes going on in the marrow. And then this is a large soft tissue component, and this is a parasagittal image. So we don't know exactly what is happening to the cord, but important thing is that you go back and forth on the sagittal imaging as well as on the axial imaging to see whether this is encasing the cord, whether this is compressing the cord or not. There's a common question that's asked is whether this is insufficiency related or pathological fracture. So pathological fractures, as I was saying about the metastases, so bulging of the posterior cortex, involvement of the entire vertebral body, and then extension into the pedicles and extraosseous soft tissue component. Those are the three things that you look for a pathological fracture. As against in an insufficiency fracture, it is more sort of restricted to the superior or the inferior end plate. You can quite often see that sort of a cleft running, and if you see it on the fluid sensitive sequence, it can be bright, and on a CT scan it might just look a fracture cleft which is running through. So that is suggestive more of an insufficiency related fracture. As regards to pathological fracture, again, you're looking for, is there a bulge? In this particular case there isn't. You're looking at the sort of pedicle involvement, you're looking for extraosseous soft tissue component. If there is none of those, then this is more likely to represent an insufficiency related fracture rather than a pathological fracture. So briefly touching on the infection, so it could be it's called a spondylodiscitis rather than discitis because the infection doesn't start at the level of the disc, it starts at the level of the vertebral end plates. It's more commonly hematogenous rather than actually arising de novo. The other thing that has to be borne in mind is it could be like post-procedural as well, so post-spinal intervention that can lead to spondylodiscitis. So it involves it starts off at the end plate, then involves the disc. So look for the signs of the inflammation, and again the paraspinal pathology as to whether there is a focal fluid collection that needs to be decompressed or something which is causing cord or cord equina compression. So this particular case, this is a T2 weighted image. So you can see that the vertebral end plates are being destroyed. You can see a stigmata of previous spinal intervention. So patient had a prior discectomy, microdiscectomy at that level. We see that the vertebral end plate is destroyed over there, and with the eye of faith, you can see that there is sort of a focal fluid collection within the sort of intraosseous abscess which is forming. Go slightly further and you start seeing this epidural focal fluid collection. So there's an epidural abscess as well, which is causing impingement or compression of the cord equina. So there was a cord equina compression which was secondary to a spondylodiscitis with an associated epidural abscess. So all these things need to go into the report, because when the surgeons are intervening or whenever they are planning to do any sort of either the antibiotic therapy, they need to be aware of all these changes, and they need to assess the patient clinically whether there is also any sort of neurological deficit. This is again a companion case which was sent to us for query spondylodiscitis. Because the patient's pain was predominantly right-sided. Looking at the vertebrae itself, there was no sort of inflammation. Sorry, this image is a bit grainy, but this is what a stir sequence, but anything which would have been bright would be more pathological. But you start seeing all this inflammatory change within the soft tissues, and we see these sort of similar changes within the soft tissues over here as well. So we brought this patient, so there was more paraspinal inflammation / infection rather than within the vertebral body or the disc itself. We had to obviously expand the field of view, and we brought the patient back and we did a dedicated MRI of the pelvis, and you can see big whopping collections in the paraspinal region involving the psoas muscles and the posterior spinal musculature. So always look at the paraspinal structures as well whenever there is a question about spondylodiscitis, because there can be other pathologies which might be accompanying those. A quick word about TB spine. It's a differential for a pyogenic infection. So how do you differentiate between the two? On imaging, you can look if there is multiple vertebral body involvement, if there is any sort of disc space, to look for the disc space, whether it's well preserved or not, and there should be the abscesses that are formed are usually thin-walled abscess. In this particular case, it is multi-level involvement, and it's the anterior longitudinal ligament which is elevated, which is sort of the prevertebral abscess which is formed. For those who've already spotted it, well done. For those who haven't, it's important to look at the spinal canal as well, and there's an epidural abscess on the posterior aspect as well, which is causing compression. Imagine there was a little disc over here, and that would just lead to sort of cord compression in this particular area. Quick word about spondylolisthesis. It's the deficiency at the level of the pars intraarticularis. So spondylolysis is just a defect over there, and whenever there is an anterior shift of the vertebral alignment, then it leads to spondylolisthesis. It's the Scotty dog appearance, that the dog has got a collar or not. So this is the pars intraarticularis. This is sort of an oblique orientation. If there is a collar through the dog, then obviously it is spondylolysis, and if there's a big collar, then it is a spondylolisthesis, and there will be sort of abnormality of the alignment of the vertebra. Important thing to put in the report, because that in combination with a degenerative disc disease can cause neural compression. So this is an oblique image of a plain radiograph. These days we rely more on CT and MRs, but if you can also pick up those on the plain radiograph as well, and you can see that the neck is intact and the neck's kind of broken in this particular case. There's a collar in this area, which is consistent with spondylolisthesis. Coming to Tarlov cyst or Perineural cyst, this is again a normal variant, and this is basically a collection of CSF around the nerves. It's a perineural cyst, usually asymptomatic. You see that day in and day out. The important thing is it should be having a CSF intensity, and if you look at the clinical, it will probably be just sort of an incidental finding. But some of the perineural cyst, which it could be perineural cyst or arising from the facet joint, can cause compression of the nerves itself. So something that needs to be borne in mind. Quick word about tethered cord. So again, a sort of a variant or sort of a congenital abnormality, so to say. In some cases just a variant, in some cases it's an abnormality. The important thing is that if there is tethering of the cord, the conus would be low lying. An important thing for the clinicians is that if the patient was having a lumbar puncture or an epidural anesthesia, it's important for the anesthetist to know where the actual conus ends, because if they imagine they put the needle in there, they can actually damage the conus. So there's something that needs to go into the report. We sometimes get requests from the anesthetist asking if there is whenever there is a suspicion of tethering of the cord, i.e. if there is a skin dimple or or any abnormality in the sacrococcygeal region, and they're suspecting that, they request an MRI scan just to look for where the conus ends, because that's important for them to know before they embark on any procedure. Coming to a brief word about scoliosis. It's a sort of a busy slide, but it's kind of divided into different causes of scoliosis. It could be idiopathic, congenital, developmental, or tumor associated. So the way to measure the scoliosis is looking at a coronal image and drawing an angle from the superior aspect of the superior end plate of the vertebra, where the curvature of the spine is, and the inferior aspect of the inferior end plate of the vertebra, of the inferior aspect of the curvature. So this is an S-shaped scoliosis, and then you've got the way to put it into the report is S-shaped scoliosis with primary convexity towards the left at the level of the mid/lower thoracic region, and the scoliosis angle, the Cobb's angle, is so you will sort of draw a line on the superior end plate of the superior segment, inferior end plate of the inferior segment, and then just calculate the Cobb's angle up there. The other thing that is important to look for is whether there is a pelvic tilt. Also count the number of the ribs, so look for any sort of segmentational abnormality. So looking at the causes of scoliosis, it could be congenital. So again, there's in this particular case, there's an abnormality of the spine. You can see the pelvis is abnormal as well, and that has led to scoliosis. In this particular case, there is a tumor which is causing the scoliosis. So the patient's trying to avoid the pain, and then it eventually leads to sort of changes in the posture, and that then leads to scoliosis. That's another example of a butterfly fragment causing scoliosis. Quick word about Syrinx. This is a dilatation of the central canal of the spinal cord, which is called as hydromelia. The syringomelia is a dissection through the epidermal lining in the central canal of the CSF collection. They are very difficult to differentiate on the MRI scan, and the terminology that we use is hydrosyringomelia. The important thing is that to establish the diagnosis, and these can present with weakness of the hands and arms, and especially the loss of pain and temperature loss. And what needs to be done about it? Well, we refer to the neurosurgeons, and depending on how much abnormality the patient is having clinically, they might or might not embark on some sort of a treatment. So the important thing is to be aware that it can occur in sort of other abnormalities such as Arnold-Chiari and Dandy-Walker, and an acquired one could be either post-traumatic, maybe related to tumor, or post-inflammatory. So if you find a syrinx lower down, we want to make sure that if you find it on thoracic spine or in the lumbar region, then you sort of image the proximal aspect to make sure there is no tumor that is causing CSF flow abnormality and leading to a syrinx. So you can see that that's a syrinx is a CSF intensity in the midst of the cord itself. Quick word about the cord blood supply. So there's an artery of Adam Clevis, which arises from the thoracic aorta, and the importance of this is that if the patient has had any sort of aortic surgeries and stuff, sometimes they can lead to, especially if there is a stent put in, they can compromise the flow to the spinal cord, and that can lead to cord infarcts and stuff. So it's important to, if the patient after any sort of major vascular procedure develops any symptoms of cord abnormality, have a low threshold of imaging the whole cord, and look for any sort of cord infarctions in on the MRI scan. Coming to the tumors, I'll just briefly touch on that. It can be divided into an intramedullary, extramedullary. Intramedullary is actually within the substance of the cord itself, and extramedullary would be arising from the posterior elements or from the epidural space, and kind of compromising the spinal canal itself. So this is a previous example was an intramedullary tumor, which is within the cord itself. So you describe it, do in contrast enhanced scan just to make sure that whether this tumor is enhancing or not, and then if need be, referred. These would be needing a referral to the tertiary center. We also, if we find any sort of intramedullary tumor, we would do a brain scan as well, just to look for any lesions high up within the brain itself. And then this is an extramedullary tumor, and again, sort of causing this meningeal enhancement and causing compression of the cord. So again, referral to the neurosurgeons. Primary tumors can happen within the spine as well. This is in the case of an osteoid osteoma. You can see the nidus within the transverse process, and this is a case of an osteosarcoma arising from the cervical vertebra itself. You can see that sunburst pattern. So primary tumors can occur within the spine. The commonest benign tumor that to occur is a hemangioma, and all you're looking for is the sort of trabecular pattern within the vertebral body itself. So what we call is a polka dot appearance. There's preservation of the marrow fat within the vertebral body, and that kind of takes you away from any sort of sinister pathology. So loss of the marrow fat on a T1 weighted sequence equates to a sinister pathology. If there's preservation of the marrow fat, then that is more likely to be sort of a benign pathology. That's just a very simplistic way of putting it, but obviously there are a few caveats to it. So we have covered trauma. So just remember the normal variants. Always look for the soft tissues, which is quite important, and have a low threshold of doing angiograms in patients who have got cervical injuries, which has gone into the foramen transversarium. The important thing about the terminology within the degenerative chain, especially there's a transitional vertebra, the traversing and the exiting nerves. When you're looking at infections, always look for the complications. We did talk about the tumor versus insufficiency fractures, so look for the entire vertebral body involvement, the posterior bulging, the extraosseous soft tissue component, and involvement of the pedicle. And we also briefly touched on the primary spine and cord abnormalities. That's about it. I'm happy to take any questions. So there was one question which has been asked by one person in the audience, is that the lumbar vertebrae, the nerve roots descend vertically, and why don't we see the entire extent on the sagittal image? So the explanation for that is that if I can bring it back to the lumbar spine again, so what we're seeing over within the lumbar spine. So this is just an example of the lumbar spine. So if you see the nerve exiting, it's kind of exiting sort of vertically, but it's kind of swirls around as well, and that's the reason why you don't see the entire the nerve on one sagittal image. You do see it exiting over here, so you can part of it, you're just kind of following it back and forth. So this is where it's going into the neural foramina, and when you're kind of exiting out, it just kind of swirls around and goes out. So if you're looking at it, this is more the sort of parasagittal region. So that's the nerve which is exiting out. So you can see quite a bit of the nerve exiting out, but you won't be able to see it on just one particular image. So it's another one which is looking at the transitional vertebra once again. So if you're looking at the transitional vertebra, there are 7 cervical, 12 thoracic, and 5 lumbar vertebrae, and then the sacrum. So you can sometimes get the lumbar vertebra, which is the L5 vertebra, which can fuse with which can partly fuse with the sacrum, or you can have the sacral, the S1 vertebra, which might not fuse with the rest of the sacrum, and that leads to a transitional segment. So you say that there is a transitional transitional vertebra at the lumbosacral junction. Now, the way, if you want to be a purist, you look for the axial image, and you look for the ligament which is which arises from the L1 vertebra. if you're struggling to see that, then all you need to do is say that there's a transitional vertebra, and for the reporting purposes, this is the there is a disc, rudimentary disc between the L5 and the S1 vertebra, and then that way is when the clinician is looking at the image, they know that, yeah, this is for the reporting purposes. That's been taken as the L5 vertebra, and then you count upwards from there. There are quite a few questions coming up. I'm just going to try to read them. In posterior arches of C1 fuse with the lateral mass. I am unsure about the exact time, but I think it's in the I think 7 to 9 years of age, but I am not 100% certain that that's probably the age, the time when it actually fuses. There is another. What is the imaging modality in suspected cord compression? And if MRI is indicated, it's CT of the whole spine. Well, yeah, the imaging modality is MRI scan, as you correctly pointed out. If there's a contraindication, then you can do a CT scan. And on the CT scan itself, if you window it properly on the soft tissue windows, you can actually look for any significant spinal canal stenosis. The other thing is that if there's obviously an osseous abnormality with an extra osseous soft tissue component, that can be picked up on the CT scan. And sometimes contrast enhanced scans also helps, because that kind of outlines the soft tissue component and can look at the so within the tumor itself there might be a bit of enhancement, and that kind of helps you to separate it from the rest of the CSF place. Any specific protocol that needs to be taken in pediatric spinal trauma condition? I am not a pediatric radiologist, but having worked in the pediatric centers before, it's the T1, the T2, and the stir sequences again. So the stir would tell you about marrow edema. So even if you don't see a definite fracture line, that would just tell you about microtrabecular injury. A T2 weighted sequence is good for looking for cord or nerve injury, and the T1 is just sort of good for looking at the anatomy and the ligament structures. We can see spondylolysis on the axial image as well. Yes, you look for so if you're going back and forth on the axial images, you see the facet joints, and when and anterior to that, if you start seeing a defect, you have to kind of obviously look at the corresponding sagittal image as well. But when you start seeing another cleft or an abnormality just anterior to the anterior and superior to the facet joints, that's the site of the pars defect or the spondylolysis. How to differentiate between pyogenic and tuberculous infection? Again, like I said, in the tuberculous infection, there can be non-contiguous involvement, and there can be multiple vertebral involvement with less destruction of the vertebral body itself, and then you see a lot of you can see the paraspinal abscesses and stuff more commonly in the tuberculous spine. How can we comment on exiting and transiting nerves? The exiting nerves are the ones which come out at the level of the neural foramina and anything beyond that. The traversing nerves are sort of at the level of the disc higher up, so one vertebral body above, and that's where the traversing nerve is coming at. So you look at the axial as well as when we are reporting our scans, we put the scan lines on the image, and you're looking at the axial as well as the sagittal imaging. So teardrop can be seen in both hyperflexion and hyperextension injuries. There was a question about whether the teardrop is more common in hyperflexion or hyperextension injuries. So it is actually the disruption of the anterior longitudinal ligament, which is kind of avulses the anterior inferior corner of the vertebra, and that leads to an extension teardrop. So, but the extension injuries are slightly more sort of intense as compared to the hyperflexion injuries. Should we include epidural fat in the measurement of the spinal canal and the lumbar spine? Well, there's an entity called as epidural lipomatosis, where there is excessive fat within the epidural space, and that in itself can cause sometimes a bit of narrowing of the spinal canal, which in combination with a diffuse disc bulge can cause problems. So in my routine practice, we have eyeball, we just need to see that if there's enough amount of CSF space there. But if there is a sliver of epidural fat and the CSF space is completely gone, I would still class that as a severe spinal canal stenosis. There's a question about end plate irregularities of the vertebrae, how to differentiate between degeneration and infection. It can be quite difficult in the early phases, especially when you're looking at Modic type 1 changes, because Modic type 1 changes, as I said, it's like more edema-like pattern, and it can be quite difficult. And there was a paper in I think the AJR a couple of years ago where they looked at the Modic type 1 changes, and all the patients who had Modic type 1 changes were given antibiotics. 80% of them kind of improved, and it was debated whether this was any sort of an inflammatory process which improved with antibiotics. But now we know for certain that that is an inflammatory change. But what you look for is irregularity of the end plate. You look for if what's the disc signal like. So in a Modic type 1 change, there will be loss of disc hydration, whereas in an infection there might still be bright signal within the disc. So that's one thing. The other thing is that you're looking for any paraspinal abnormality. But if you're in doubt, then obviously need to embark on sort of repeat imaging in 4 to 6 weeks time. But again, it will all boil down to what's the clinical suspicion. We don't usually use the sort of measurement criteria itself. What we look for is what's happening to the CSF space, because measurement criteria can be different in different trusts, and if you're it all depends on what your spinal surgeon's thoughts are. So if they look for any specific measurements, there are different measurements which are available, but our spinal surgeons do not want us to put any measurements down. We class that as like mild, moderate, and severe spinal canal stenosis or Kodak compression. I think there's a question about spinal canal stenosis again, which is what we look for: the area, the AP dimension, or the or subjective. So if you're looking for spinal canal stenosis, such as in this particular example, what you're looking for is that's the dura, that's the CSF within the dura, and there's the nerves which are coming out. So, and that's the epidural fat. So what you're looking for is this enough amount of breathing space for the nerves. When I come down, this is sort of narrowing of the spinal canal, but again, the CSF space is sort of well maintained. So this is still be classed as sort of, if anything, just about mild level of or just causing indentation of the thecal sac. For me, moderate is when it's sort of the nerves have got just a little bit of CSF space, CSF between them. A severe one is when I completely lose any CSF within the spinal canal. So that for me would be severe spinal canal stenosis. What about short pedicles causing stenosis? So like I said, there can be congenitally short pedicles which might not cause any problems on their own, but when it is combined with any degenerative disc disease or any tumor, that can lead to severe spinal canal stenosis. So we put that in the report, whether there's the spinal canal appears to be constitutionally narrow, and whether or not in combination with another pathology that is leading to severe like mild, moderate, or severe spinal canal stenosis. There's a can called perch facet versus locked facet. So perching of the facets will be when it's usually seen with just a unifacetal facetal dislocation. So you kind of seeing one facet on top of the other. So you just, whereas in the locked facet, it is completely dislocated and it's kind of gone more posteriorly. So if I may draw. So if you can imagine, that's the facet. So this will be a normal facet, one on top of the other, whereas in a perch facet, it'll be just sort of just lying on top of it. And then in a locked facet, it'll be a more severe grade where that's what's happened. So that is locked. So what the spinal surgeon would need to do is distract this upwards, and then this should kind of come underneath it. So this is what normal facet versus perch facet versus locked facet. How to differentiate between sequestered disc and a mass lesion? Well, it can be quite difficult sometimes. What we need to look for is what's the signal of the sequestered material and whether it is the same as the degenerative disc in that particular location. If it's similar, that's what we say. The other thing that you can potentially do is give contrast in those cases and see if there is any enhancement. Sequestered disc would usually not show any sort of enhancement, but that can be happening with a tumor as well. So it's something that you need to sort of suggest and look for the adjacent signal abnormality within the disc itself. Spondylolisthesis without listhesis at times becomes difficult, and diagnosis on MR. Is there any technique to see it? Well, the important thing is that when you're looking at a sagittal image, you are kind of so what you're looking for on the sagittal image is looking at the pars intraarticularis. So that's a superior articular facet, that's an inferior articular facet, and you're looking at the pars intraarticularis. So you should see a normal sort of T1 marrow signal in continuity, and that's what suggests that there is no pars intraarticularis defect. If there is a low intensity line, or if there is a loss of the normal marrow extending in the pars intraarticularis, that would be suggestive of a spondylolysis. I think that sounds fine. Right. Okay. Thank you. Cheers.